Hello and welcome to today's Talking Point presentation. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples listening to today's Talking Point or listening in the future. My name is Rowan O'Gell, and I'm the Strategic Lead of the National Addiction and Mental Health Surveillance Unit here at Turning Point, and a Senior Research Fellow at Monash University, and I'll be facilitating today's talk. Talking Point is a regular series of publicly available lectures that aim to inspire, inform, and challenge our notions of what we know about addiction and mental health and their impact across society. Today's Talking Point is a hybrid webinar with attendees both online and here with us in Richmond. We love our webinars to be interactive and to be as interactive as possible. So please ask questions via the Q&A function if you're joining us online. Sean will respond to questions at the end of today's presentation. For those in the room, you're also welcome to ask questions at the end. Note that all of our webinars are recorded and available to view on the Turning Point website. So now I'd like to introduce our presenter. Sean Drummond is a Professor of Clinical Neuroscience and Director of Research Programs and Infrastructure in the School of Psychological Sciences at Monash University. He received his PhD in clinical psychology from the University of California, San Diego and San Diego State University Joint Doctoral Program, and has held positions in the VA San Diego Healthcare System and the Department of Psychiatry at UC San Diego prior to coming to Monash University and the Turner Institute for Brain and Mental Health in 2014. Dr. Drummond has an incredibly impressive track record, having published more than 150 outputs, including a first author paper in Nature. His work has been cited more than 10,000 times, and his work been funded by diverse sources, both here in Australia and in the United States, including the National Health Medical Research Council, the National Institute of Health, the National Science Foundation, the US Department of Defense, and many industry partners. Dr. Drummond is a past president of the Sleep Research Society, a group of more than 1,200 experts and leaders in the sleep discipline. He's also an associate editor of Sleep, which is the leading discipline-specific journal. There are three related arms to Sean's program of research: cognitive neuroscience of sleep and sleep deprivation, behavioral interventions for insomnia, and translational studies examining the mechanistic role of sleep in psychopathology, especially PTSD, which is the topic of today's talk. So please join me in welcoming Sean to the Talking Point series.
Thank you very much, Rowan. And thank you very much to Turning Point for the invitation to come speak today. It's a real honor to be here. As Rowan said, I'm going to be talking about sleep in the context of PTSD, largely from a clinical perspective, but I'll touch on a few other things first. Before I get into sleep in PTSD, I'm going to just talk a little bit more about sleep generally and how we think about it from a scientific perspective. Maybe things that folks have heard before, but just kind of want to get everybody on the same page about what sleep is, how we think about it. Then I'm going to talk a little bit about the bidirectional relationships between sleep and mental health more broadly before transitioning into most of the talk focused specifically on PTSD. So first, let's just sort of define sleep and what we're talking about here, and particularly define the various stages of sleep. One of the things that I find fascinating about sleep is that it is not one state of consciousness, but rather sleep is two distinct states of consciousness. One of them is called rapid eye movement sleep, or REM sleep. This is a stage of sleep where we do most, although not all, of our dreaming. In a healthy adult, it takes about 20% of the night. And when we are not in REM sleep, we are in the state of consciousness called non-REM sleep. So sleep folks aren't particularly creative, and we couldn't think of a better name. So it's REM or it's non-REM. Non-REM sleep is further broken down into the very creative stages 1, 2, and 3. The bigger the number, the deeper the stage of sleep. So stage 1 is kind of this transition stage where you're not really sure whether you're awake or asleep, and your mind is kind of wandering, but you don't have a lot of control over where it's going, and you kind of hear things around you, but you're not really processing them. This is stage 1 sleep, and it's typically a very small part of the night, maybe 5-10 minutes of the night. Stage 2 sleep, I like to think of as the Goldilocks stage of sleep. It's not super deep. It's not super shallow. It takes up about 50% of the night in a healthy adult. And then finally, stage 3 sleep, which is also called slow wave sleep or deep sleep or delta sleep. This is our deepest stage of sleep. It's the I'm sleeping like a log kind of sleep. It's hardest to wake us up out of this stage. We feel most groggy if we do wake up out of stage 3 sleep. And this takes up about 20% of the night as well. Now, sleep can be characterized in a number of different ways. But one of the interesting things about it is that it's not a simple linear process. We don't fall asleep, get some stage 1, some stage 2, some stage 3 REM sleep, wake up, the night is over. Instead, we move back and forth between these stages all night long. And this is an example of that. So this is what we call a hypnogram. And effectively on the x-axis, we have time. And so this is a healthy young adult somewhere in their 20s. I can't remember exactly what. They spend 10 hours in bed, as you can see here. Time is on the x-axis. The y-axis is the various stages of sleep with REM, wake, stage 1, stage 2, stage 3. You can see the lights turn out. They're awake for a very brief amount of time. They get just a little bit of this transition stage 1 sleep, and then stage 2, and they drop into this nice long period of deep slow wave sleep. When that's done, they bump up to a slightly more shallow stage of sleep, and then they get their first REM episode right here. So this whole thing here is called a sleep episode or sleep period. It takes about 80 to 100 minutes to go through this cycle right here. And then you can see it repeats all night long again and again, but it doesn't repeat in a symmetrical way. So the beginning of the night is really dominated by this deep slow wave sleep. One of the reasons for this is deep slow wave sleep is one of our markers of sleep need. So the longer we've been awake, the more our brain needs sleep, the more of this stage 3 it's going to generate. You can also see that in the second half of the night, REM sleep is much more dominant. It occurs more frequently. It lasts for longer periods of time. There's relatively little deep slow wave sleep. This is an influence of our circadian system that is driving REM sleep to be happening this time of night. It also means, thinking about PTSD, that most nightmares happen in the second half of the night because that's when we're getting most of our REM sleep. So this is a good, young, healthy sleeper. We contrast that with this, which is an individual with chronic insomnia. They're also in their mid-20s. You can see they didn't spend quite as much time in bed here, and that the sleep looks very different in the hypnogram. So first, there's this big chunk of pink at the beginning of the night, which is basically restless wake. They're tossing and turning, trying to fall asleep. They then fall asleep. They get a little bit of this stage 2. And then instead of a nice big chunk of deep sleep, it becomes very fragmented, where it's deep and then more shallow and then deep and more shallow, and they're moving back and forth. They can't sustain the deep sleep. The other thing you can see is there's lots of the yellow going through here, which is periods of very shallow sleep, and lots of blank where there's no color at all, which is when they're awake. So this is an individual who had very bad middle insomnia, where there's lots of wake periods, including one really long one in the middle of the night here. Overall, there's very little deep sleep. There is relatively little and fragmented REM sleep. And so you can see it looks very, very different. And while this is a patient with chronic insomnia, this is also what sleep in PTSD often looks like: very shallow, very fragmented, and very broken up REM episodes. Now, we can pull lots of characteristics of sleep out of these sorts of data. The two kind of global measures of sleep that are helpful to think about, though, are first, sleep quantity, which is characterized by total sleep time. That's simply the total number of minutes that we're asleep during our sleep period or overnight. And then sleep quality, which we hallmark with a variable called sleep efficiency. Sleep efficiency is simply the percent of time that we're trying to sleep that we are actually, in fact, asleep. So if we're in bed for 8 hours and we're asleep 6 of those hours, sleep efficiency is 6 divided by 8, or 75%. And a healthy adult should be sleeping about 85% of the time or more. So that's kind of the benchmark for healthy sleep efficiency. Okay, and not only does sleep evolve across the course of the night, but of course, not surprisingly, sleep also evolves across our lifetime. So this is the result of a very big meta-analysis with 3,500 or so individual data points in here. This is looking at the way sleep evolves across age from age 5 to 85, as you can see here. The x-axis is age, the y-axis is minutes, and the different shades of blue are different stages of sleep. So stage 1, stage 2, SWS stands for slow wave sleep, which is stage 3, REM sleep. WASO is wake after sleep onset. So this is how much wake in the middle of the night somebody has. Sleep latency is how long it takes to fall asleep. And so all of this color together is essentially the time somebody's in bed trying to sleep. And I should say that this is data, these are data only from healthy sleepers. So no sleep disorders, generally no psychiatric conditions, just good, healthy sleepers to give us a sense of what is, quote, normal. And what you can see, of course, is that kids and early adolescents spend a lot of time in bed trying to sleep, and that really drops across the course of time. Kids also get lots of deep slow wave sleep, lots of deep stage 3 sleep here. This is a stage of sleep that's associated with rest and restoration. Growth hormone is secreted during this stage. So it's needed quite a bit in kids. And then as they start to age and as we get some neuronal pruning in the brain, as it starts to sort of prune back, we get reduced slow wave sleep is probably the biggest thing that changes from late childhood into adolescence, is a drop in deep slow wave sleep, as well as a little bit of REM sleep. And then an interesting thing that many people don't quite realize is that from about our mid-20s until our mid-60s, sleep is pretty stable. There's not a whole lot of changes on average in sleep during this period. Then after about 65, as we start to age, what we see is that there's a drop in this deep stage 3 slow wave sleep and a commensurate increase in the amount of wake time in the middle of the night. So it's hard to generate sleep overnight. And the reason for this is, I'm not going to go into the details, but the reason for this is a change in our circadian rhythms. So the circadian rhythms is the biological process that drives us to be awake all day and drives us to be asleep all night. That process starts to break down a bit as we age. So the ability to stay asleep all night long starts to break down. That we definitely see in terms of the deep slow wave sleep and the increase in the amount of wakening. And there's a commensurate decrease in the drive to be awake all day long, which is why older adults will often have a desire to nap much more than they did when they were younger. Okay, so with that sort of very basic overview of sleep, how it evolves across the night, how it evolves across the lifetime, let's get more into the heart of what we're talking about today. And I want to start, before I jump into PTSD, to talk a little bit more generally about sleep and mental health, because of course, the clinicians working at Turning Point and affiliated, and even clinicians working with PTSD are going to see a lot more than just trauma. There's a lot of mental health conditions that are going to be on the plate. And there's a strong bidirectional relationship between sleep and mental health, almost all mental health conditions. In fact, if you look at the DSM-5, something like 80 or 85% of the diagnoses have some sort of sleep disruption as one of the diagnostic criteria. So there's a very strong relationship. However, there's a handful of mental health conditions for which the strength of the relationship going from sleep to mental health is stronger than the relationship going from mental health back to sleep, even though it's still bidirectional. And in particular, if we have poor sleep at baseline, particularly insomnia, it will predict the onset of a new diagnosis, even if somebody has never had a mental health condition before, and or predict an exacerbation of ongoing symptoms in these disorders I have up here. So post-traumatic stress disorder, insomnia predicts the onset of PTSD. It's also the case that nightmares emerging immediately after a traumatic event will predict the onset of PTSD. But insomnia also will predict the new onset of depression, of bipolar disorder, of substance abuse, particularly alcohol and stimulants, and of suicidality. Both suicidal thoughts and behaviors are independently predicted by insomnia. And what I mean by independent is independent of mood symptoms. Insomnia predicts an increase in suicidality. Now, sleep doesn't only predict the onset of a new diagnosis or a new mental health condition, but if somebody has a mental health condition, they get it treated, and they are now in remission, a new episode of insomnia can predict a relapse into mental health conditions, particularly these: depression, mania and hypomania, alcohol dependence in particular from a substance perspective, and psychosis. So these are things where if you are working with clients and they have a background with one of these disorders, even if they're stable, if sleep problems emerge, that could be the canary in the coal mine that other things are going on that might lead to a relapse. And so it's something you want to start paying attention to. Okay, so now let's get into sleep and PTSD. So 70 to 90% of individuals with post-traumatic stress disorder report sleep problems. The 70% range is civilians who maybe experience a single trauma. The 90% range are veterans, first responders who are exposed to multiple traumas throughout their lives. But regardless, there is a whole lot of people with PTSD that also have sleep problems. It is extremely ubiquitous. Insomnia is the most common sleep problem seen in the context of post-traumatic stress disorder. Nightmares are probably the most unique. So there is something known as idiopathic nightmare disorder, where there's no apparent reason for somebody having chronic nightmares, but it is a very low prevalence. So the vast majority of the time, somebody with chronic nightmares has a trauma background and it's related to PTSD. In addition, the prevalence of obstructive sleep apnea is very high in PTSD. So for those who don't know, obstructive sleep apnea is a sleep disorder where you stop breathing at night. So it's usually characterized by fairly loud breathing and then a pause in the, fairly loud snoring, and then a pause in the snoring, which is actually a pause in the breathing. So the person's airway becomes completely shut and obstructed and they can't get any air down. The only way to start breathing again is to wake up and then start breathing again. And then this occurs over and over and over again all night long. So sleep becomes very fragmented and is associated, because people aren't breathing, it's associated with oxygen deprivation or hypoxia. So it's a very nasty sleep disorder. Its prevalence in the general population is about 10%, depending on age and sex that you're talking about. But in post-traumatic stress disorder, the prevalence is 60%. So it's much, much higher. We don't know exactly why this is, but it's an active area of research trying to figure out what is the mechanism driving high rates of OSA and PTSD. Now, regardless, both insomnia and obstructive sleep apnea are associated with an increased risk of PTSD. And one way to think about this is if somebody has either insomnia or sleep apnea at baseline, they are then exposed to a traumatic event, they are 2.5 to 3 times more likely to develop PTSD than if they had not had insomnia or sleep apnea before being exposed to that event. So it's a very potent risk factor having this sort of sleep disruption. Interestingly, though, even though I've just told you there's lots and lots of sleep problems in PTSD, almost everybody with PTSD has a sleep problem. Pretty much any study out there that examines sleep in the context of PTSD will say that there are sleep difficulties in PTSD. But interestingly, there's relatively few consistent findings in terms of which aspect of sleep is disrupted and the magnitude of that disruption from study to study to study. And this was a real head scratcher for a while. And a few years ago, our group published some data and proposed that the reason that there's such a lack of consistency in the data in sleep and PTSD is because one of the sleep features that characterize PTSD is extremely high levels of variability. So night-to-night variability within a person and person-to-person variability across the population of people with PTSD. And I want to show you just a little bit of data from that paper that backs up this argument. So first, let's look at, excuse me, night-to-night variability in the context of PTSD. So these graphs are from a group of individuals with, so I should back up. In this study, we compared a group of veterans with post-traumatic stress disorder to a group of individuals with chronic insomnia disorder, but no other psychiatric condition, and a group of healthy controls, all age matched. And what we have here is individual data across the course of a week. So the x-axis is days of the week, so 1 through 7. On the y-axis is the sleep variable, whatever it happens to be. In this case, the top graph is self-reported total sleep time from a sleep diary. The bottom graph is actigraphy-based sleep efficiency. So an actigraph is a wristwatch-based device like a Fitbit or an Apple Watch or something like that that measures sleep and wake. So we have both a subjective and an objective measure here. Each line is one person across the 7 days. And so you can see in chronic insomnia, there's a reasonable amount. You can sort of just get the gestalt image. There's a reasonable amount of night-to-night variability. These are not flat lines. They're kind of going up and down. With respect to sleep efficiency, there's a few people that got really poor sleep efficiencies on a few nights. Compare that now to the people with post-traumatic stress disorder, and you can see that it's even more variability. There's even more up and down night to night here. So we have a significantly greater amount of night-to-night variability in both total sleep time and sleep efficiency in PTSD relative to insomnia. If we then look at inter-individual variability, that is individual between people within a given diagnostic group, here I've got all three groups on there. So PTSD on the left, insomnia in the middle, controls on the right. The top is some self-report data, so diary-based data. The bottom is the objective actigraphy data. On the left is total sleep time, sleep quantity. On the right is sleep efficiency or sleep quality. And in every single case, you can see that the folks with PTSD have much more between subject variability than do the other two diagnostic groups. So there's much, much more inter-individual variability here. So more night-to-night variability within a person, more variability across people. And then finally, if we look at diurnal rhythms, so one of the things that these wristwatch-based sleep trackers can give you is a diurnal rhythm, which is basically looking at the pattern of sleep and wake across the 24-hour cycle across several days. So it's a proxy of circadian rhythms, which we can really only measure biologically, physiologically, I should say. This top left one, I'm not going to go through all these, but this top left one, interdaily stability, this is how stable is the sleep-wake rhythm from one day to the next. So you can think of it as a measure of night-to-night variability. And you can see that the folks with PTSD have much greater night-to-night variability in their sleep-wake rhythms than either of the two other groups, either insomnia or healthy controls. Upper right is relative amplitude. So this is how strong is the circadian rhythm. That is how strong is the drive to be awake all day and how strong is the drive to be asleep all night. And you can see here that there's much greater variability among the people with PTSD, so the inter-individual variability, than there is in either of the other two groups. So these data are showing that it's not just sleep that has greater variability within PTSD, but it's also rhythms that have greater variability within PTSD. And so given all of this, it's not surprising that when we work with individuals clinically who have post-traumatic stress disorder, they talk about an inability to predict whether they're going to get a good night of sleep or a bad night of sleep or how bad the night of sleep is going to actually be. It's just very hard to understand and predict from day to day. And we've started sort of thinking about this as sort of the nocturnal chaos of PTSD in this constant and variable sleep disruption. Okay, so clearly sleep problems are ubiquitous. They're variable, they're hard to predict. And so this should logically suggest that we should do something about this. We should try to treat sleep in PTSD. And this is where the sort of the rest of my talk is going to be. And I should say from now on, when I sort of generically talk about sleep in PTSD, I'm really just talking about nightmares and insomnia. Even though I showed earlier there's lots of other sleep problems, these are the two that we have approached the most clinically and that, frankly, the literature has dealt with most clinically. So that's really what I'll be talking about. Okay, so one thing you might think about in treating PTSD is, well, sleep is just a symptom of PTSD. If we treat the PTSD, sleep will resolve. And frankly, this is the mistake that people in psychiatry have been making for decades, thinking that if they just treat the mental health condition, sleep is going to get better. It almost never does. And that's true in PTSD as well. So the gold standard exposure-based interventions for post-traumatic stress disorder, of course, are very good at treating daytime symptoms, but they have very minimal impact on nighttime symptoms. So even in an otherwise successful treatment where the person's daytime symptoms are under control and they're not experiencing problems anymore, their CAPS score is way down, the sleep symptoms are typically still residual. So they are still there and they're typically still in the clinical range. So that suggests then that we need to treat sleep specifically in the context of PTSD. And fortunately, there are good evidence-based interventions for sleep problems. So there's imagery rescripting treatments for nightmares, although sort of in more recent years, we've started to realize their efficacy is a bit equivocal. There is CBT for insomnia, which is clearly the gold standard intervention for insomnia in any population that's experiencing it. Although I'm not going to talk about it today, there are multiple interventions for obstructive sleep apnea. The gold standard intervention, which is positive airway pressure, which essentially is a mask you wear that blows air down your airway all night long, is not well tolerated in PTSD. And so there's a lot of work going on right now to understand which of the other interventions are better tolerated in the context of post-traumatic stress disorder. However, all of these sleep treatments have some benefit on daytime symptoms of PTSD, but very modest. So typically very small effects on daytime symptoms. So now we're at a situation where daytime treatments for PTSD don't fix the nighttime symptoms. Nighttime treatments for PTSD don't fix the daytime symptoms. So what do we do? Well, what we and others have argued is that we need to treat the full 24-hour symptom profile of PTSD. We need to specifically target the daytime symptoms, and we need to specifically target the nighttime symptoms. Now, to my knowledge, there have been 3 efforts in the literature to do this, to develop interventions or combinations of interventions that specifically target this full 24-hour symptom profile in the same individual during the same course of treatment. What I'm going to do now is show you data from our clinical trial where we did this. We were the first ones to publish this attempt to do a full 24-hour treatment in PTSD. And this was in a study back when I was in San Diego that we called Project Nights, the Nightmare and Insomnia Treatment Efficacy Study. So what we did in Project Nights is we enrolled veterans from the Iraq and Afghanistan wars who had post-traumatic stress disorder and diagnoses of both insomnia and nightmare. So they had sort of the whole mess going on. Everybody, when they first started the study, got prolonged exposure as our gold standard daytime PTSD intervention. The way that we did the PE was 2 sessions a week across the course of 6 weeks. So it was a bit intensive. It was 12 total sessions. Then they were randomized either to sleep treatments where they got imagery rehearsal therapy for nightmares and cognitive behavioral therapy for insomnia, or they got supportive care therapy, which was a very Rogerian influenced kind of non-specific, be really nice to them and have good rapport sort of control intervention. So it really just controlled for time with a therapist. And I should say the imagery rehearsal therapy was 5 weeks and the CBT for insomnia was 7 weeks. And the supportive care therapy for the people who got assigned to that was 12 weeks of that to match the length of the sleep interventions. A little bit about our study participants. So you can see we had a total of 45 individuals, mostly men, which is kind of matches the veteran population in the United States. It's a relatively small number for a clinical trial. So I think we need to think about these, and we certainly talked about this in the manuscript, that this was really a preliminary study testing sort of the efficacy of these interventions in this population. They were in their mid-30s. Most of them had, well, maybe half of them had multiple deployments to various war zones. You can see the types of places to which they were deployed. And because we were in San Diego, the individuals were dominated by Navy and Marine veterans, which sort of matches the San Diego population in general, though we did have some people from the Army and a few from the Air Force. Okay, so let's sort of jump into the results. So the first question we wanted to ask is, did phase one, that is, did prolonged exposure help either the daytime or the nighttime symptoms, right? And of course, it better have helped the daytime symptoms or we weren't doing it, right? Because PE has very good data. So the way these graphs work, we'll go to the daytime symptoms first. The way the graphs work is I've got baseline pre-treatment on the left and post-prolonged exposure on the right. Whatever the clinical measure is the y-axis. And then I generally put some sort of clinical cutoff with a dashed line. So this is the CAPS score, the clinician-administered PTSD scale. So this is the gold standard measure for diagnosing PTSD. This clinical cutoff here is moderate levels of symptoms, or moderately severe PTSD. And what you can see is people started really high on the CAPS, just like we'd expect them to. Giving them prolonged exposure over the course of 6 weeks led to a significant decrease in CAPS scores with a medium to large effect size and got them almost down to that moderate range. Now, we also looked at depression because depression is extremely highly comorbid with post-traumatic stress disorder. And so it seemed like the best second psychiatric outcome. And again, we saw a significant drop in the PHQ scores with a large effect size. And again, we got people down almost to the moderate levels of symptoms. So even after this gold standard intervention, people were still at moderately severe both PTSD and depression symptoms, which is not uncommon given the format of PE that we administered. Because it was only 6 weeks, even though it was twice a week, it still wasn't that long to bring the symptoms down. So this is where they were at the end of PE. Okay, so now the question is, does PE affect sleep? And I already told you that at best it has modest effects on sleep. So let's see what it did in our trial. So our main insomnia outcome variable was sleep efficiency, which is this measure of sleep quality. Higher is better. This clinical cutoff is 85%, which is gets you into the normal range. And you can see that there was a non-significant increase in sleep efficiency with prolonged exposure, and it's a small to medium effect. So there was really an effect on sleep efficiency that was not in any way clinically meaningful, really. We then looked at the number of nightmares as our main outcome variable for nightmares. Now, there is no sort of normal range, or at least no well-accepted normal range for the number of nightmares somebody should have per week. We sort of a priori kind of arbitrarily picked 2 nightmares per week. If we got people down to that, we would feel that that was a clinically robust response. And you can see that after prolonged exposure, people went from about 7 nightmares per week, so basically 1 a night, at baseline down to just a little bit more than 4 nightmares per week. So that was a significant decrease in the number of nightmares at a small to medium effect size. So again, arguable how clinically meaningful that drop is. Certainly, it's good to go from 7 to 4, but having 4 weeks still sucks. And so it certainly didn't get far enough. Okay, so here we are. Prolonged exposure seemed to help daytime symptoms of PTSD and depression, did not do a whole lot for the sleep symptoms. What happens? Oh, no, before I get to that, I have more sleep symptoms to show you, just to drive home the point it didn't help a lot. So the Insomnia Severity Index is the most common self-report measure of insomnia symptoms that is in the field, both clinically and research. And certainly, as a clinician who isn't specializing in sleep, if you want a single measure to give your clients to look at sleep symptoms, the ISI is really the one to do. Folks started in the moderately severe range of the ISI. They ended in the moderately severe range of ISI. So again, even though this was statistically significant, it's not a particularly clinically meaningful drop in ISI scores. And then because we had, before this trial, published the night-to-night variability data, we wanted to see whether any of these interventions could reduce night-to-night variability and bring some predictability back to the sleep of these individuals. And you can see that there was a non-significant change in night-to-night variability on self-report sleep efficiency. So again, prolonged exposure isn't doing a whole lot to help sleep. So now the question is, if we add sleep treatments onto the back of prolonged exposure, can we improve clinical outcomes, either daytime clinical outcomes or nighttime clinical outcomes? So first, let's look at those daytime clinical outcomes. If we look at CAP scores, so the graph has changed slightly here. So I still have baseline, post-prolonged exposure. And then this next set is people who had 5 weeks of imagery rehearsal therapy in the purple, or 5 weeks of our control condition in red. And then the final set of bars is an additional 7 weeks of CBT for insomnia versus 7 weeks of supportive care therapy. So that's a total of 12 weeks of sleep treatment or 12 weeks of control. We lost about, just in sort of full disclosure, we lost close to 50% of our participants between phase 1 and phase 2, which is not uncommon in PTSD trials, unfortunately, but we didn't start with a whole hell of a lot to begin with. So at this stage, we really do need to think of these sleep data or the data from the second phase as fairly preliminary. But with that said, because it's preliminary, I'm not even going to show you p-values. What I am going to focus on is effect sizes. And the way we calculate the effect size, it's what is the difference between the two conditions, sleep versus control, after the first 5 weeks of treatment relative to where they ended PE? And where are people, what is the change after 7 weeks of CBTI versus the control treatment relative to where they stopped after PE? So the end of PE is our new baseline, effectively. And what you can see is that in terms of the PTSD symptoms, the CAP scores, both groups got a little bit better for the 5 weeks following prolonged exposure, but there was no differential change between the two conditions. So treating nightmares with imagery rehearsal therapy didn't do anything extra to help PTSD symptoms. And you can see that it's got a very, very small effect size. However, when we then treated insomnia for 7 weeks, now we got a significant difference between the two groups at a medium effect size, where adding CBTI did indeed improve PTSD symptoms. And in fact, you'll see that the group who got all of the sleep treatments and completed CBTI is the only group that ended the trial under the clinical threshold for probable PTSD on the CAPS. So this is the only one we got into the non-clinical range in terms of PTSD symptoms. Now, if we look at depression, it turns out that neither of the sleep treatments did anything to really help depression. And this was really surprising to us because there's very good data showing CBT for insomnia has robust positive effects on depressive symptoms. But they did not in our sample here. And I don't know if this is because of the way depression manifests in the context of PTSD or some other explanation. We don't really know, but we didn't really do anything to help depression in these folks. Okay, so does adding sleep treatments to the back of prolonged exposure benefit sleep? We better hope it does because that's what they're supposed to do. But let's take a look at the data. So first, if we look at sleep efficiency, you can see that, yes, indeed, both the nightmare treatment of imagery rehearsal therapy and cognitive behavioral therapy for insomnia had robust benefits to sleep efficiency. And in fact, you can see the control condition, actually, their sleep got worse in terms of sleep efficiency after we stopped prolonged exposure and they went into the control condition. And effectively what this means is their sleep became more fragmented. So they had more awakenings, less sleep in the overnight period. However, when we treat sleep, it gets much better. And again, people who finished the entire sequence of sleep interventions are the only group who ended in the normal range for sleep efficiency at the end of the study. If we look at the number of nightmares, technically, imagery rehearsal therapy did lead to a large effect size improvement in nightmares, Cohen's-d of 0.97. But when you look at the data, actually what happened is that the group who had prolonged exposure and then moved into the control treatment, their nightmares came back and they got worse. Whereas imagery rehearsal therapy did almost nothing for nightmares at all. And as a side note, well, at the time, when we first did this study, this was surprising because we all thought imagery rehearsal therapy worked pretty well. More and more data has come out showing that any of these rescripting therapies have very weak effects on average. So in general, they work for some people very well. They work for other people not at all, and it averages out to very little effect at all. And the definitive IRT trial really kind of brought this home and showed this. I've got thoughts on why that is, but that's not really the point of what I'm going through today. Though I guess if there's questions, I can talk about it at the end. Regardless, though, even though IRT didn't do anything for nightmares, interestingly, CBT for insomnia did improve nightmares. So treating insomnia helped to improve the nightmares. And as we've seen in other areas, the only group who ended up in what we a priori defined as the normal range, or in this case, clinically meaningful improvement range, the only group who got there was the group who got the entire course of sleep treatments. And the fact that CBTI helps nightmares has now been replicated in a couple of other studies. In fact, Tom Nyland showed this before we did, and now Daniel Taylor has replicated in some of his data as well. Okay, moving on to the Insomnia Severity Index, which is that main insomnia questionnaire. You can see again that both imagery rehearsal therapy with its focus on sleep and nightmares and CBT for insomnia with its focus on sleep improved insomnia symptoms. Again, it's not terribly surprising. We had large to very large effects here. Although interestingly, we did not get people into the normal range for the ISI, which in this case would be below 8. For our night-to-night variability measure, again, both sleep interventions had robust and meaningful improvements in night-to-night variability on sleep efficiency. So we were able to get sleep to be a little bit more consistent night-to-night and a little bit more predictable, which just anecdotally, I should say, working with these clients, that predictability of sleep was the biggest self-reported benefit, the biggest perceived benefit that they had. So even if they weren't sleeping as well as they would like, the fact that it was predictable and it was consistent made a really big difference in their quality of life. Okay, so conclusions then from this trial. First, prolonged exposure, which is clearly probably the #1 gold standard intervention for PTSD, improves daytime symptoms of PTSD. It simply does not improve the nighttime symptoms of PTSD in any clinically meaningful way. And this has been shown not just in our study, but in multiple studies. It's also been shown in cognitive processing therapy and trauma-focused CBT. However, adding evidence-based sleep interventions to prolonged exposure had small, but I would argue in some cases meaningful impacts on the daytime symptoms of PTSD. It showed, not surprisingly, large to very large effects on the nighttime symptoms. And giving people interventions for this entire 24-hour symptom profile of PTSD, both the nighttime and the daytime symptoms, is the only combination of interventions that got people into the normal range on a number of our measures, although clearly not all of the measures. And then what these really argue, I think, is that we do need to provide both traditional gold standard daytime interventions for post-traumatic stress disorder and nighttime specific sleep interventions for those symptoms. We simply need to find a more efficient way to do it. So the trial that I just showed you was 18 total weeks, 6 weeks of PE, which was twice a week, and then 12 weeks of sleep treatments once a week. Of course, there's homework associated with all of this, diaries, practicing the exposures. These is a really intensive intervention. Daniel Taylor, who has replicated these findings with cognitive processing therapy, had a 22-week intervention that he did all total. That's just too much to expect anybody to really go through. That's a lot of psychotherapy. It's a lot of really intense psychotherapy. And particularly our populations, both the one that Daniel studied and ours, were relatively young veterans from the Iraq and Afghanistan wars. These folks have families. These folks have jobs. They go to school. It's just too hard to do this much psychotherapy for this long, no matter how much pain they're in with respect to their mental health. And so we have to find more efficient ways to do this. The third group who has done this type of 24-hour symptom profile intervention, it was led by Peter Kolvanen, again in San Diego, where he's tried to integrate prolonged exposure and sleep interventions and not do them sequentially, but do them simultaneously. So within the same session doing them. His clinical trial data has not yet come out. So we'll sort of see how that goes, but I'm excited to see where it goes. And I think we need more creative ideas of how do we do all of this in a more time-efficient way. Okay, with that, I will stop. I don't have any idea how much time is left, but I'm sure there's plenty for questions. So thank you very much for your attention, for your time. Happy to answer questions.
Thank you, Sean, on such a wonderful talk. We do have lots of questions, so I'm going to start asking a few that have come online.
Okay.
And then, of course, we have an audience here who may wish to ask some
A live studio audience.
So a live studio audience, that's right. So I'm going to walk you back towards the beginning of your talk where you showed a wonderful graphic on sleep across the lifespan in healthy adults. Are there any data or knowledge that we have on clinical populations and what they look like before they're diagnosed? So with PTSD, are there any risk factors that we can pick up from how someone sleeps to find out whether they're going to be at risk of developing PTSD?
Yeah, that's a good question. So I think really what we know is what I alluded to in a couple of the slides, which is if you've got sleep difficulties, particularly if you've got insomnia at baseline, and then you are exposed to a traumatic event, you're much more likely to develop PTSD than if you're a healthy sleeper before the traumatic event. And then the same is true if you're a healthy sleeper, you're exposed to a traumatic event, and you develop sleep disruption in the immediate aftermath of the trauma during the sort of acute stress part, you are more likely to go on and develop PTSD. So having good, healthy sleep seems to build some resilience to the development of a full-blown PTSD. And there's a couple of sort of hypotheses around the mechanistic explanations about that, which wasn't part of the question, but I'm going to tell you anyway. One of them is related to the role that sleep plays in basic fear processes. So there are basic fear processes, particularly fear conditioning and fear extinction, that underlie not only post-traumatic stress disorder, but pretty much all fear-based anxiety disorders. And what we know is that REM sleep in particular plays a mechanistic role in these fear processes. So if you have fragmented, disrupted REM sleep, you in particular have impaired ability to develop fear extinction memories. So in essence, you can't unlearn fear once it's been learned. And that then makes somebody much more susceptible to developing PTSD or trauma because all of these exposure-based interventions for PTSD and anxiety are based on fear extinction. The second mechanism that is hypothesized, but we don't have as much data on yet, and it's an area sort of active research, including with one of my PhD students, is that disrupted and fragmented sleep seems to promote, we believe, promotes intrusive memories, right? So one of the symptoms of PTSD, and again, other anxiety disorders, are intrusive memories where particularly strong sensory memories of the traumatic event come back into the head, and people end up ruminating about them. They come involuntarily, and there's good reason to believe that sleep disruption, particularly a lack of sleep, maybe more so than sleep stages, promotes the development of intrusive memories. And we know that development of intrusive memories also predicts the development of PTSD. So that's kind of what we think is going on.
Wonderful. Thanks for a very comprehensive answer. You took one of the follow-up questions I was going to ask you.
There we go.
So that's all right. We're on the same train. As you know, I also have an interest in sleep and studying sleep. And I want to dig in a little bit more into this high prevalence of OSA in people with PTSD, particularly to try and find out about, is this a central kind of apnea? Is this disrupted airway style apnea? And what impact this actually has on people's everyday life with PTSD, particularly given the low effectiveness or uptake of CPAP?
Yeah, so the data seem to suggest that so for those who don't know, there's really two types of sleep apnea. One is called obstructive sleep apnea, which is really what I was describing, where the airway becomes obstructed. It closes down across the course of the night. You cannot breathe anymore because your airway is shut, and the only way to start breathing is to wake up. There's another one called central sleep apnea, which, as the name might suggest, is actually because the brainstem isn't sending a signal to even try to breathe in the first place. So it's sort of centrally generated lack of breathing. And they give you slightly different clinical presentations, although I'm far from an expert in apnea. The data seem to suggest that the type of apnea you see in PTSD is more obstructive than central, which means it should actually respond to the same interventions that treat obstructive sleep apnea in any other population. I think the problem with the CPAP devices is that any of the positive airway pressure devices require wearing a mask either across the mouth and nose, or just the nose, or sometimes even just this pillows, they call them, under the nose that blow airway in. And the folks I've worked with PTSD describe very strong claustrophobic feelings associated with that. And so that leads to a lot of rejection of the intervention, which is why that then now there's a lot of effort to see if any of the other secondary treatments for sleep apnea are more acceptable in this population.
Thank you, Sean. I now want to bring you forward in your talk to your night study, which was a wonderful piece of work that I think you explained really well across the different phases. In that study, did you look at the content of dreams or nightmares? And can you comment on whether that differs between people who have PTSD, a healthy population, and those with other sleep disorders?
Yeah, well, so maybe I'll take the second part first. So I think the thing that characterizes the nightmares in PTSD relative to some other populations, or I mean, we all occasionally will have nightmares, is the thematic content of the nightmares in PTSD. So some individuals will have nightmares that are just replays of the trauma, right? You pop in the DVD and it just plays every night. DVDs aren't that common anymore. You turn on the streaming service and it plays the same nightmare every single night, with what seems like good fidelity of the traumatic event. Others will have thematic nightmares, but aren't necessarily replays of the trauma. So one of the ones I remember really clearly, an individual I worked with, his thematic nightmare. So he was a rescue diver in the Navy, and he almost drowned multiple times, and that was his series of traumas. And so his nightmares every night would be of suffocating, but different types. So sometimes it was drowning, sometimes it was being in the shower and the water getting in his face and he couldn't breathe. Sometimes somebody would be smothering him with a pillow. There was all kinds of variations on this. And so they weren't a replay of the trauma, but they were clearly thematically related to the trauma. In contrast, otherwise healthy sleepers or even other psychiatric populations will typically have more random nightmares. And or we all will have our sort of pet stress dream that can turn into a nightmare under the right kind of stressful circumstances. So that's sort of the difference between them. And then the question, did we measure content in Project Nights? Yes and no. So we measured content to the extent that a re-scripting intervention for nightmares will take the most common nightmare that somebody has and get them to re-script to the end of that nightmare into something neutral or positive. So at that level, we had to have some sense of content of the repetitive parts of the nightmares, but we did not track them in terms of every night, if they were having nightmares, what were those nightmares? Were they the ones they were re-scripting? Were they something different? So we didn't collect that sort of data.
Thank you. So I might ask our audience now, the in-person live audience, do you have any questions that you'd like to ask Sean? Please.
Is there any data on like the relationship between PTSD and sleep, and whether that's like was a similar or different pattern with straightforward PTSD?
Are there any data on complex PTSD and sleep? So the short answer is not that I know of. I think the sort of diagnostic awareness of complex PTSD is relatively recent. And it, by definition, is complex and highly comorbid. And so I don't know of any papers that have specifically looked at that. Sort of what I would suspect. So one of the things that is common in complex PTSD is also a diagnosis, or at least features of, say, borderline personality disorder. And the sleep in borderline personality disorder looks similar, actually, to what it would look like in PTSD. There's a much higher prevalence of nightmares. There's a higher prevalence of disrupted insomnia like sleep. In the past, we've typically attributed that to the fact that there's often a trauma background in these individuals, and so it's hard to know sort of what's driving what. But that's about the best I could say, and that's vaguely speculative. So I just don't think those data are out there yet.
Thanks, Sarah. Any other questions for Sean?
Yes.
Are there any plans to do similar research on different kinds of groups who, like, say, first responders or something like that, that have maybe a different kind of PTSD?
Yeah, that's a really good question, because right now, all the groups who have tried to do this 24-hour sort of intervention have been in veterans, and in U.S. veterans at that. So yes, we need to do it in other populations. I would love the opportunity to do that. I've not yet gotten funded to be able to do that, but I would like to be able to do that. And in particular, I would be really interested to do it in people who are still actively working in the first responder industries, in part because they are further complicated often by shift work. And that adds sort of a whole new layer of complexity to it, which requires some thought in how to integrate into the overall intervention and how best to treat that. And I think there's a huge need there, obviously, but I'm not aware of anyone who's tried to do that work yet. Yes, ma'am.
When you said, I know you spoke a little bit about the time periods, like, the 22 sessions and things like that.
Yep.
Do you have any idea of how long the benefits would last? Like, is there kind of a maintenance schedule that people need to stick to after the therapy, or?
That's a tremendously good idea, or a tremendously good question. None of the studies have done any kind of follow-up. So I don't know. We did a 3-month follow-up, which was not a very long follow-up. And we didn't give a booster session. We just sort of did a follow-up of the data. And the sleep gains were relatively well maintained at 3 months. I can't remember the PTSD symptom data right now, but it would not be, given the severity of symptoms at baseline, having some built-in booster sessions is not at all a bad idea, because I think that certainly we know PTSD symptoms can flare up and come back and be triggered by various things. Sleep symptoms certainly can. The beautiful thing about CBT for insomnia, though, is that when you look at the literature, because what CBT for insomnia does is teach people a whole new set of behaviors to manage their own sleep-wake habits. Follow-up data, like 6-month, 12-month follow-up data from CBT for insomnia trials, are often better than the post-treatment data, because as people continue to engage in these new behaviors that you've taught them as part of treatment, their sleep continues to get better and better and better over time. In this particular population, again, I don't know. Those data are probably out there, but I don't know them off the top of my head. Regardless, booster sessions are probably not a bad idea in a population that starts this severe. So that probably wasn't a very good answer to the question, but it's the best I could do.
I have a related question to that, actually, Sean, that it's incredibly intense as you presented that kind of presentation and then clinical work. Is there any hope for brief interventions in this space, or is that really a pipe dream?
I think from a trauma symptom perspective, it's probably a pipe dream. I certainly haven't seen anything that has suggested that brief interventions would work. There have people who have tried doing daily prolonged exposure for hours a day to try to speed it up. And we'll see how those data, so it has been compressed quite a bit. And the trials using a compressed version of prolonged exposure lead to generally the same quality outcomes post-treatment as the more extended version. But I don't know the long-term data and how well it sort of maintains over time. And they're still relatively new, so there's relatively few of those trials out there. So maybe I shouldn't say it's a pipe dream. It's not a complete pipe dream. In terms of the sleep interventions, we're constantly trying to make sleep interventions shorter and shorter. There's people in the field who think that's the wrong way to go. But it's as short now as 2-3 sessions, and you get a robust response in an otherwise non-comorbid individual.
Thanks, Sean. At that, we're at time. So I would like to say thank you to everyone who's attended, both online and in person, and for the wonderful questions that have come through, leading to a nice discussion at the end. But mostly to Sean, thank you for a wonderful presentation, very clear, really important work. And to all those funders who are listening online, please do fund those first responder studies for Sean to do. For everyone here in the audience, please join me in thanking Sean.